Hi everybody, welcome to Dr Manny's YouTube LearnShops. This is part 7, the weaning process according to your organisational policy, but generically we look at veno-venous extracorporeal membrane oxygenation and how you might go about weaning the patient from it and the criteria that might be required. So when we review, we're looking at patient considerations, physical assessment, vital signs. We're looking at blood gas assessments which deal with pre-saturation oxygen levels and post-saturation oxygen levels, arterial blood gas assessment, chest x-ray assessments, what infusions should be weaned, and conclusions. So, when it comes to physical assessment, if we're considering weaning, what should the patient demonstrate? They should be alert, orientated, warm, pink, have palpable pulses and be well perfused. Their vital signs should reveal a core temperature normal between 36 and 37 degrees centigrade, a pulse rate between 60 and 100 beats per minute, respirations 12 to 20 beats per minute, a normal blood pressure 120 on 80 with a mean of 100. Saturations, peripheral, should be 94%. They should be pain-free and they should have a capillary refill time of less than 2 seconds. Additional vital signs to consider are level of consciousness, preferably the maximum score 15. Additional signs to consider: heart rate 60 to 100 beats per minute, sinus rhythm, CVP between 0 and 6 millimeters of mercury, a pulmonary artery pressure of 20, diastolic 10, mean of 15, a pulmonary artery occlusive pressure between 6 and 12, end-tidal CO2 monitoring, capnography, 40 millimeters of mercury, a urine output of 1 to 2 mils per kg. When it comes to blood gas analysis, if we're looking at the oxygenator, pre-ox should be 65%, post-ox 72%, and improving. Improving, pre-ox 70%, post-ox 75%. Improving, pre-ox 75%, post-ox 98%. When we're looking at venous saturation, blood gas analysis, it should be improving. We're looking at saturations here, SVO2 86%, 89%, 90%. The blood gas is essentially normal. Chest x-ray should also be improving. This is demonstrating ARDS. Should be improving. Still not perfect. Improved air entry. Lungs are becoming blacker. Perfect. Hopefully, clinically, they're the same. Because remember, the chest x-ray gets sicker last compared to the clinical picture in a patient with acute respiratory distress syndrome, ARDS. That's what we want, to see an improvement both clinically and through investigations such as blood gases, chest x-ray. When it comes to IV infusions, the patient will typically be on vasopressors, sedation and analgesia, and these should be ceased or therapeutically low when you're considering weaning. Norepinephrine should be ceased. Epinephrine should be in the lower range, typically less than 0.1 micrograms per kg per minute. Vasopressin ceased. Dopamine at a renal dose, 5 mics per kg per minute. Fentanyl and midazolam and neuromuscular blockades should be ceased. When it comes to weaning as well, the sweep gas inflow should be set at 0 litres per minute. Weaning's only commenced by reducing the pump flow in the ECMO circuit. The sweep gas flow is reduced to 0 litres per minute through the membrane oxygenator. The sweep gas flow rates are equal to blood flow, so therefore the sweep gas flow should be equal to cardiac output. Sweep is the setting that controls the carbon dioxide removal from the blood. This is in your weaning process for VV ECMO. When it comes to conventional mechanical ventilation, recommence depending on the mode. Now the physician will order the mode. I've just put here synchronized intermittent mandatory ventilation, whether it's volume control with pressure support or pressure regulated volume control. And typically the ventilator settings would be a frequency or rate of 12 to 20 breaths per minute, tidal volume 5 to 7 mils per kg, a minute ventilation with a PaCO2 of 40 millimeters of mercury, FiO2 less than 60, PEEP 5, peak inspiratory pressure less than 30, and peak plateau less than 30 centimeters of water. I've astrofixed there here now the minute ventilation and the oxygen, because again, you may require higher oxygen doses, but this is what would be recommended. Minute ventilation determines by your PaCO2. Low oxygen percentages would be better. Less risk of oxygen toxicity. When it comes to arterial blood gases, you're aiming for a PO2 of greater than 60 millimeters of mercury, a PaCO2 of less than 50, and a PaO2 of greater than 90 millimeters of mercury. Echocardiography can be of benefit as well, because it will demonstrate whether there's any evidence of cor pulmonale, right heart failure, which could be something that influences whether the weaning process is successful. Observing the patient during the VV ECMO trial is vastly important. Vital signs should be temperature 36 to 37 degrees, but certainly less than 37.5 and greater than 36. The pulse rate should be between 60 and 100, certainly less than 120 beats per minute. Respiration should be 12 to 20, less than 30. Blood pressure should be 120 on 80, but certainly greater than 90 and less than 130. SpO2 should be greater than 90 and less than 100, so about 94% in that range. The patient should be pain-free, but if they do have pain-free, certainly less than 4 out of 10 on your numerical scale. Skin perfusion should be a capillary refill time of less than 2 seconds, but again, this relates to either central or peripheral. Additional vital signs, their level of consciousness, they should be alert and orientated. Glasgow Coma Scale, 15 out of 15 would be ideal. Heart rate, less than 120. Heart rhythm, no tachycardia, no premature ventricular complexes. Central venous pressure, certainly less than 15 millimeters of mercury. Pulmonary artery pressure, not necessary, but if we do have it, less than 30 millimeters of mercury. Their wedge pressure or their occlusive pressure, less than 20. Their capnography and total CO2, less than 45. Preferably between 35 and 45, and their urine output at least 1 to 2 mils per kg. Arterial blood gases, what should we expect? Well, we should expect them to be within a normal pH range, with a nearly normal PaCO2, a normal PaO2, hopefully, normal acid base, and a saturation between 94 or at least 94%, between 94 and 100%. There we can see improving, PaO2 92, PaCO2 40, pH normal, saturations 94% normal. Chest X-ray, what should we expect to see? Well, we should expect to see an improvement. Here we have the ARDS picture with increased infiltration, alveolar edema. We should expect it to improve. That's what we would like to see, a normal chest X-ray. Okay, that's the end of part 7. in your VV ECMO Dr Manny Learn shops. If you found this of any benefit, please recommend it to your colleagues, subscribe. I'd like to see you involved, and most importantly, move on to part 8 and 9. See you soon.